The next speaker is Upendra Bhojani, who is a faculty and a PhD scholar at the Institute of Public Health. He studies how to strengthen the local health system to improve chronic disease care for the urban poor. He is also involved into media and legal advocacy on public health issues. Welcome, Upendra.
Thank you very much, sir. And yeah, being one of the organizers, I hardly had time to put together this thing in the last days, but I'll try my best to be in the time. I have 10 minutes.
10 minutes. We can keep about 12 minutes.
Thank you. Okay, so in next 12 minutes, I'll try to sort of reflect on what are the challenges from system point of view in organizing chronic disease care for urban poor areas. And I would particularly take diabetes as a pointer, but I think most of these challenges probably apply to most of the chronic conditions. Just for a background, I think well-documented thing that the India is urbanizing at a very rapid pace. Over 30% of the population today live in urban India. And with this, there is also an epidemiologic transition. So we have more and more chronic conditions. In fact, I think way back in 2005, chronic conditions were responsible for more than 50% of the deaths in the country. And since then, of course, the morbidity is also going up. But with urbanization, there is also an increase in the slum dwellers, the number of the slum dwellers. If we refer to the 2001 census, quite old, itself says that more than a quarter of the urban population lived in slums, and nearly the same proportion of the urban Indians lived below the poverty line. And so within urban areas also there is huge intra-urban inequities, and I think the chair of the session has done pioneering work in showing these inequities within urban India, not only in terms of larger social determinants in terms of access to piped water supply, housing, sanitation, but also access to health care, and hence the difference in the health parameters of various strata in the urban India. But despite that, there is a neglect of the urban poor somewhere in most of our health schemes and policies, and recently many researchers have voiced it out. And also somewhere the neglect of the chronic conditions, because most of our systems, health delivery systems, are particularly meant for the episodic care. So something like chronic conditions which require sort of a long-term care, lifelong care, a follow-up where patients play a bigger role is something that probably not being responded to. So in this context, I would like to use various data sources to show that what are the challenges from a health system point of view. So the important word here is, I think today for me, is from health system point of perspective, because chronic conditions or diabetes can be studied in many ways, but here I would try to limit myself to look it from a health system lens. And when I say urban poor, I particularly refer to a finite geographic area called Kadugondanhalli or KG Halli. It's one of the ward of the Bangalore city, and it's not far from here. And I'll use that as the geographical setting. So, of course, there are many frameworks available to look at health systems. And what I will use today is the one which is called Health System Dynamics Framework. It's developed by the people at the Department of Public Health, Institute of Tropical Medicine, Belgium. It basically uses all the health system building blocks which WHO also speaks about. But in addition, it sort of portrays or allows us to see the sort of dynamic interactions between various components of the health systems and how it affects the outcomes and the overall goal. And of course, being a social system, it's embedded in a context, and it's really the value and principles of the actors who are involved also shapes the system. So with that, let me take you to KG Halli. It's one of the ward of the Bangalore city, less than a square kilometer of area, but around 45,000 people live there, and it has one of the notified slum area. It's quite a social mix, so it's not really a kind of a slum probably. I come from North India where I see, so it's quite a mixed neighborhood. You have pockets of vulnerable population, but also there are well-off people. And it's really a social mix because people have probably migrated over the years from the adjoining states. So there are 4 different languages spoken within a square kilometer area. And most of the population follow Islam, nearly 70%, followed by Hindus and Christians. So what I do is I use different data generated by Institute of Public Health in KG Halli, because IPH is conducting an urban health project in the area since last 3 years. So these are all the data generated for the same area over the period of 4 years. So we started with a household census covering over 9,000 households. It was conducted between 2009-2010 as a baseline to the project. And the main aim was to understand the self-reported morbidities, where do people go to seek care, and how much money they spend. So, and as part of the project, we have a series of meetings with healthcare providers. And when I say that it includes private and public, whenever myself and my colleagues go to the area, we try to do some sort of writing in the what we call field notes, some ethnographic observations. I include that in the analysis. And more recently, this year, as part of my PhD, I conducted a study where I interviewed selected diabetic patients, a phenomenological approach where we try to do in-depth interviews and try to understand on patients' terms as to what are their experiences of living with the disease, how it affects their social position, what did they do to assess the care, and etc. And I also interviewed healthcare providers in KG Halli and around KG Halli, which basically included around 14 doctors, 2 pharmacies, and 2 laboratories. And here, it was more structured around the framework which I described earlier, to see how care is being organized within their local setup. So with that, I just remind you that now I use various data which is generated over the time in KG Halli, and try to use this framework to look at that. So if you see the first component, the leadership and governance, as Professor in her keynote address said, there is a diversity of the providers, and particularly so in an urban area. So you have in the KG Halli, we have at least 32 private providers, 1 health center run by municipal corporation, 1 health center, or rather community health center, which is run by state department, which used to be a sort of a rural health service, but now got included with the expanding city. So actually no administrative integration across these players. So we have a common wall shared by urban health center and the community health center, but they don't speak to each other, they report to different authorities, and there is not even referrals across. So there is absolutely no, but also there is very poor operational integration, because there are resources in the area, but divided across the players, but there is hardly a sort of networking. Karnataka Private Medical Establishment Act, it's something in line with the Clinical Establishment Act by the state government, but in my interviews only 2 GPs recollected that yes, there is something like that, and one of them was registered with it. But none knew about this regulation, which is there since 3 years. Most of the, in around 32 general practitioners, 3 are trained formally into the Western medicine, allopathy. But all the providers I interviewed reported practicing Western medicine, and despite not having formal training in that discipline. I interviewed people who are managing the pharmacies, and at both the places, these people were not trained pharmacists, and both laboratory as well as pharmacies reported to me in audio recorded interviews that there is a prevalent practice of kickbacks. Particularly, laboratory says that it ranges from 25 to 30%, and the pharmacy says it's somewhere around 10-15%. If you see the resources, most of the resources for treatment of the chronic conditions, or diabetes in particular, are lying in private sector in that particular area. And so if you see the specialist, of course, urban health center is meant to be a sort of primary care center, but even in the community health center, which should have at least 4 or 5 specialties, did not have any specialist. And it is being upgraded, but the process is on since 3 years, and still somehow they have not been able to put together the kind of structure that should be there in CHC. In private hospitals, they line up a list of consultants, but they all are on-call basis. So when there is a patient, they try to call them from a nearby tertiary medical college. So there are most of the professors who come and then serve as the consultants. If it is the medicines, there are no medicines at urban health center. At community health centers, metformin is available, no insulin, but of course there are frequent stockouts, and once there is a stockout, the next indent can happen only after a year in a routine indent cycle. Well, they say generally use of generic medicines is kind of an effective way of reducing the cost. But what I observed is all the pharmacies, private pharmacies, had generic medicines. But they were sold at par with branded medicines, even sometimes at a higher cost than the branded medicines. And so most often it was not the doctors who were prescribing it, but it was used by the pharmacies to give it as replacement to the brand medicines because it was fetching a larger margin to the pharmacies. If you see the finances, a very grim picture emerged because nearly 70% of the people with chronic condition had to make out-of-pocket payments on their outpatient care itself. And nearly 16% of the households suffered financial catastrophe, meaning they spent more than 10% of their household income onto the outpatient care. I'm not talking about inpatient here. And if I reflect on my analysis, it shows that within 1 month in KG the number of the people living below poverty line doubled only because of the out-of-pocket payments on outpatient care, and I'm not including inpatient here. If you see the information systems, only 5 GPs reported use of some sort of medical record system, and it usually meant to be a small diary, but there was no follow-up system, and this was patient retained system. So in case if a diabetic doesn't report back, no one knows what happened. So there is no active follow-up from the health service side. And role of population was quite, in contrast to the rural health systems where I worked a bit, there was no sort of participation. There were no platforms for the people to participate. So mainly they were basically funders. To a certain extent, they exercised choice in the providers because there were many providers around, but depending on their on their capacity to afford it. There were self-help groups, but mainly focusing on the microfinance. The health was not really a component in it, but still, sometimes it helped them to fetch money for the treatment. So in summarizing my last slide, I will try to again go back to the same framework and try to see whether there is any way forward. So of course, background factors are very macro, and for that you need healthy policies beyond the health sector. But at least something like NUHM, which is being discussed over probably more than 3 years, has still remained in the draft. Lot of programmatic focus. So everybody, when you ask about GP, they all talk about immunization, maternal health. So everything is sort of a programmatic. If you see the leadership and governance, apparently in a system, in a small area where such a diversity of the health providers exists, you need some sort of steering, and probably state can play that role. But most often the impression you get is that, we don't care about private sector, whatever it is. And there is an existing mechanism like Karnataka Private Medical Establishment Act, but there is hardly awareness among the providers about it. If you see the resources, I think the state has now started a scheme to provide low-cost generic medicines at the tertiary centers. But if something like this can be extended, then probably it can reduce the cost, because my study shows that nearly 70% of the out-of-pocket expenditure happens only on medicines in terms of chronic diseases. So financial protection, of course, because 40% of the households in the area did not have ration cards, so they cannot get enrolled into RSBY, which is now available in Bangalore. But even some other schemes where usually it's based on BPL, and I'm happy, I think recently Vajpayee Arogasi is talking about having slum dwellers included rather than going by the BPL card. And of course some reorientation of the services, moving from episodic care focus to rather something where we talk about having a sort of continuity of care. And we certainly need to see how we can engage people in the planning and management health services. I end with this photo. So this project tries to see whether we can work with all the providers, private as well as the public, and to bring them on a common platform where the community representatives and all the health providers sit together and discuss about the local issues. It's quite challenging journey. I think if you want, you can get more information from the stall of the IPH, and there are some facts around it. Thank you very much. Sorry, I think I took a little more time.
Thank you, Upendra.
Thank you.
Thank you.